to...
So we just took Stephanie's x-rays. We took 5 different views. So we're going to see how all of them turned out, and we're going to check the image criteria and make sure this is ready for the radiologist to read. So let's start off with the first view. It's the AP projection. So here we can see that the knee is fully extended by how straight the femur is above the tibia. We see slight superimposition of the tibia, of the fibular head behind the tibia, and then we can clearly see that there's symmetric, the femoral condyles are in profile and they're symmetrically shown. There is also no rotation of the knee because it's straight. So moving on, and also we can see the trabecular pattern of the bone, and you can also see the soft tissue. And proper collimation, of course, because we didn't get too high up on the femur or too far below. You know, our orders are always put in specifically by the doctors, so we want to make sure we fulfill that and don't also overexpose our patient for the exam at hand. So all of these should display proper collimation. Moving on to the second one, I think I skipped one. Okay, yeah. It's the AP projection medial oblique position. So right away we see again proper collimation. The tib and fib are separated at the proximal articulation, and we can see the posterior aspect of the tibia. It's kind of on the posterior side, and we see that patella kind of projecting off slightly to the side where the femoral condyles are. We can see the open knee joint right here, and we are able to still see both tibial plateaus are in profile and the lateral condyles of the femur and tibia. So that will be right here and right here. Those are both in profile on the left side of the image. And we'll move on to the third image, which was the medial lateral projection. That's a mouthful. So we can see here that the knee is flexed about 20 to 30 degrees. Again, Stephanie had no trauma, so she was able to get her knee straight for the AP and flex her knee as much as I needed to flex it for her for the medial lateral projection. We also can see that the fibular head and the tibia is slightly superimposed. We can see that right there. It's little. The patella is fully in profile. Sometimes you can see that little fibella sesamoid bone behind the knee in the popliteal space, but we don't really see it right now, but that's okay. That's not what we were looking at today. The patella is also on the lateral aspect, which is good. And we can see an open patellofemoral joint right there. Here's the femur, here's the patella. That joint's nice and open. We can see that dark space, so we know soft tissue is going through it. And also a joint space, an open joint space between the femoral condyles and the tibia. So that will be right here. Here's the femoral condyles, and then here's the tibia down here. And you can kind of see the tibial plateaus where it dips down a bit at the top. And again, proper collimation, we can see the soft tissue and the trabecular pattern of the bones. Wider where it's more dense, of course, towards the end of the bones. So now, fourth up, we have the PA axial intercondylar fossa. I use the Kemp-Coventry method for Stephanie. So we can see open intercondylar fossa, which is this space right here. It's all in the name. The posterior inferior surface of the femur condyles, that's right here. So we see that that's posterior because we're looking at the back of the knee, and it's inferior because it's the lower section of those condyles. The apex of the patella is not superimposing over the fossa, so it's a clear intercondylar fossa. We can see the patella isn't dipping down, blocking, which just shows that her knee was bent enough, but not too much to start closing off the joint space. It's always a sweet spot. There's in this one, there's slight tib-fib overlap. We can kind of start to see it right here on the lateral side of my image. And it's centered, the intercondylar eminence, which is this right here, between the two tibial plateaus, is centered, which means her knee wasn't rotated. It was straight even though it was bent. And the knee joint is nice and open, so those tibial plateaus we can clearly see. So last but definitely not least is the tangential projection of the knee. I use the Houston method. That's the easiest for me. I find that most patients can do it. Those with prosthetics, even some of those with a slight injury, they're able to do it. But again, Stephanie had no trauma, so this was nice and easy for her to perform. This is familiarly called the sunrise because we can see that nice sunrise of the patella in profile here, and we can see the condyles of the femur. We can see the medial and the lateral condyles. We can see the patellofemoral joint space is nice and open. We can see that dark space means it's open there because that's soft tissue running through it. And we can also see that it was collimated really well. It doesn't need to be as open. It doesn't need to be 10 by 12 like a usual knee one. It's much smaller because it's just a small little section trying to look at that sesamoid bone and make sure it's all okay. Thank you for making sure Stephanie's 5U knee series was all A-okay, and hopefully the radiologist enjoys those pictures and he can read them and get back to her doctor soon. Thank you.